So welcome to week 9. Remember, next week is your exam 3, the final exam in the course. It is a bunch of reviews are out. I've just added the last 2 professors' review times. There's one Tuesday, Wednesday, Thursday, Friday, and Saturday. So there's all different times for you. I do mine on Wednesday at 5 o'clock. Remember, I do post them all. I'll put them in one announcement and I'll just keep editing and updating it so it's all in one place. So you don't have to look in 5 different places for where is that review link so I can go look. As I always say, at least listen to 2 reviews. It gives you 2 different views. There are some people who go to every live review, believe it or not. And every time I see their name over and over again, I'm like, wow. But it's reflected in their grades. This one that I'm thinking of has a 99 average because of 198 so far. I think that's just amazing, but it is the live reviews and that's what she'll tell you. She'll tell you who she likes best, but it doesn't matter. She said everybody has something to offer, and I think that's the point. So this week we're going to go over chapters 48 and 49. This is your neuromuscular and musculoskeletal dysfunctions. So we're going to talk about things like CP, muscular dystrophy, and issues with your bones, whether it's breaks, sprains, or some conditions that have to do with the bones. So I want you to know that the clinical assessments that you did for me, the ones that I've read already, I have been very impressed. I was very happy with them. If I send you, if you see a grade that is not above 90, go into the comments and look at what I've wrote for you. You can redo them, okay? If you have submitted the first one before last night at midnight, you will get no deduction. I'm giving you the opportunity the second week to get the best grade you possibly can, okay? So if I say you didn't put reference somewhere, or you put your teaching like this, but if you put it on a PowerPoint or a pamphlet, it would have been better. I'm telling you, go back, just let me know you've redone it, and I will regrade it for you so you can get your best grade, okay? 6% is a lot on your subjective grade. I have actually seen not doing this or doing this assignment poorly has actually failed a student last semester. So don't let that be you. Make sure that you do get it in and you turn it in. You have till Sunday, okay? And anything last week, let's say you didn't get to it, because there's quite a bit, just get it in by Sunday, and at least you can get some good credit on it, okay? And I will be doing the rest of the assessments tomorrow. So just go and look at it, see if you need to update anything, send it back in, and just let me know. Just send me a message, okay? So that's all I need from you.
Turning it in late, that would be a 10% reduction in grade, right?
Okay. After Sunday. But if you've done it and I tell you to redo it, that's not a 10%. That is, you put it in on time. You just need to give me something that makes your grade a little better. I want you to get the best grade you can. That's my goal. And I think you learn from it. I mean, if you're an associate graduate, like I was as a brand new RN, as an associate degree graduate for 32 years. But today, a lot of facilities are looking at BSN and MSN and higher, in order to be in management, et cetera. You'll be going back to school. So this is your first time doing projects. I'm trying to teach you how to do it better so that you can do better for your BSN or your MSN. Okay, that's why I do this for you. Do I remember? I went back and I know that I didn't know what a PowerPoint was. I didn't know APA. I didn't understand anything. So at least you guys have a little understanding, more than I had when I went back. So now I have not graded them all yet. As I said, I'm going to try to finish them tomorrow. I only have 4 classes of 20 some odd students per each class. Now, I did go all weekend long and I did check them on Thanksgiving, on Friday, on Saturday, on Sunday. So I've tried to keep up with what was turned in. And I think all of you who've already got a grade understand that. But if you turned it in late last night, I have not had a chance to do anything today. I had a class earlier, then I had something else I had to do. And then I have your class tonight, so it'll be tomorrow. All right, let's go ahead. Let's get you to your PowerPoint. Any questions, anybody? So musculoskeletal, articular dysfunction, it could be traction, it could be a harness, it could be crutches, it could be casts. We're going to be talking about these. So first of all, let's talk about an immobilized child. This is a child who can't get up, move around like a normal child. It could be due to many different reasons. It could be that they were born that way. Could mean that, and we're going to go later into this, they had a myelomeningocele and they have no feeling in their lower extremities. So they're in a wheelchair for life. Could be some degenerative disorders like osteogenesis imperfecta. We're going to go into that later too. Could be some injuries, infections that cause it. And we know that if you're immobilized, we need to keep that body moving. There's all those side effects that can occur if we lay in bed too long, right? Or if we're too sedentary. So the muscular system, we don't move, you're going to have muscle wasting and your muscles aren't going to be strong. So we need to do that range of motion as much as we can, considering what diagnosis. The skeletal, we know the bones demineralize, and cardiovascular, that's something that we always talk about. That is the heart's not beating as good, venous stasis, blood clots, dependent edema. All of those things create so many problems that we try to prevent. And if a child is immobilized, what do? Turn position, cough deep, breathe, do some massages, passive, active, range of motions, all of those things can help here. Now, if you have a kid who can't get around and we haven't given them any device for them to move. Maybe this is a child who just had a car accident, has a fractured pelvis, let's say, and they can't move and they're stuck in the bed. These children, if they're there for a while, can get very angry. These kids probably will get that aggressive and lash out at you. They're looking at 4 walls all day long. So how would you feel after a month of that? Especially if you were, let's say, a young teenager or even a school-age children, and your parents can't be there all the time. So making sure that we give these children enough environmental stimulation in order to keep them, not as focused on their inability to move, but giving them things to do. I mean, this is where child life comes into it, where they can go in and they can play with them and have them do things, and it'll make a child feel much more better, or betterer if you want to call it, but they can feel better. Now, get a kid, put them on. They're immobile. And let's say it's a long term. Let's say the child has cerebral palsy. Let's say that child does have myelomeningocele and they can't get up and move around as much. This is the whole family has to work with this child. Does it disrupt family function? Well, it puts focus on one child, not all of the children in the household. So children who are immobile, remember that the family does need support. I think about those siblings at home, or those siblings that always have to wait for their brother or sister to get them situated so they can move with you. It can become frustrating, and parents, they'll do anything for their child. And, that's what a parent is. But, it does get frustrating for them. So allowing them to verbalize about their feelings, like, I'm just angry. I just want to get up and go and I can't. But I feel bad because because it's my child and I need to take care of my child. And we don't think about those things, but it's a real thing. So many type of conditions have a some sort of group where they get together. I know at the hospital that I worked at, every floor, different specialty, had a family group. That meant that they met about every month, sometimes more frequently depending, but they shared what was going on. And when you have a parent group that you have sets of parents coming in, or even just mothers or just fathers, and they can share how they feel, it makes them feel better. So getting them involved, that does help, especially long-term immobilization. And then of course, having individual counseling, that's always good. They can talk, just a one-on-one with somebody. So traumatic injuries, this is those muscles, ligaments, tendons. This is something that happens, kids fall, trip over something, or they're out playing sports and, they have, sprained their ankles, bruised something, bumped in something. This is what kids do. They're always getting a bump, a bruise, or something. Poor little Christian, a couple weeks ago had a bump on his head because he fell off the handlebars of the bicycle onto cement, and now he had a big ecchymotic bruise on his head. Well, 3 days ago, he was making a fort out of the pillows in the living room and was underneath them and going quick and on his hands and knees and ran into a wooden chair and has a 2-inch laceration underneath his elbow on his eyebrow. It was like gushing blood, and I'm like, okay, we have a boo-boo, so we had to fix that. But these are kids. This is what happens to kids, and we need to be prepared for them. So contusions, bruises, well, they're really nothing, right? You think of them, they're nothing. But remember, we don't see the whole part of the damage. Remember, bruising is blood creating space in a place that shouldn't have it, squeezing vessels, and it could cause lack of blood flow to go places, especially if it's a crush injury. Something fell on them, or maybe a car hit them, or they're on a bike and they fell off and then the bike smashed them, or these crush injuries, you can't tell the extent. So when we're thinking about contusion, yes, we see the bruise, we see the swelling. Remember, check your neurovascular signs, check for pulses, because distally it may be occluded. A simple bruise could be something more than a simple bruise. Now, dislocation is something that can happen with children. The most common is when you take those little toddlers by their arms and you roll them around and their elbows disjoint, called a nursemaid elbow. And it dislocates because their tendons are soft. They're not as strong as an older person. You take them to the doctor, the ER, they go click and it's back in. You let that elbow rest for a period of time and you don't do that again to them and they're okay. Down's children can take their feet and put them behind their heads, both of them. But it causes because they're so hypotonic, they're so flexible. But remember, putting it behind their head has the possibility of hip dislocations. And when you dislocate your hip, your blood supply is gone. So we have to be very careful with these Downs children, especially to do that. Sprains and strains. I mean, how many times have you sprained your ankle? I know I played sports, high school and in college, and volleyball was the big one that I used to always sprain my ankle, go up, spike a ball, come down and right on the ankle, and you could hear it. And it's like, oh, this one hurt. Big trauma to the ligaments, and it stretches and it creates some of the blood vessels to tear, and you get these big ecchymotic area and it causes swelling and it is very painful. Strain is when you do something to an area and stretch it beyond what it should have been. It's similar to a sprain, and we do the same treatment, which is RICE. We want to rest it. We want to ice it immediately. Put an elastic bandage on there, an ACE bandage, they're great, and elevate it. I know when I used to go down after spiking a ball and getting my ankle, my foot would go straight up in the air because I knew that that was the way to decrease swelling that's going on. You know, years ago, bad sprains, they wouldn't put any sort of splint or cast on them. They have found out today that putting a cast on, keep it symmetrical, and actually it aids in healing. They didn't do that years ago. Again, showing you the evolution of what we do differently in medicine today. Fractures. Well, fractures are common, kids fall down. You know, this kid with the bilateral wrist fractures you see here, you know, a couple years back, they came out with those little hoverboards where you put on them and you put your feet like this and it motorized and move you around. Well, some parents, yeah, they had helmets on their head. Okay, that's great. But they didn't put on those wrist protectors. And when they fall, there's nothing to grab. So what do? Their hands go out, both of them. You know how many bilateral fractured wrists that I saw? Both bones and both hands. I saw 2 that immediately after Christmas, and I saw 1 later on about a week after they started back to school. It's because, you know, they're, you know, especially those adolescent 10 to 14-year-olds that had them, they had no fear and they're trying to run these boards and move as quick as they could, be really cool, you know, and they had bilateral fractured wrists. So be careful. You know, wrists are the most common. You fall, what do? Your hands come out, right? You're protecting your head and it's okay. Now, infants. Infants should never have a fractured bone. Their bones are soft, they're malleable, and it takes a lot of force to fracture their bones. Now, I did have a case of child abuse, and it was a kid who came in with swelling on the side of the head, and it was a fractured skull. We did a bodygram, what we call it, x-ray the whole body, had a fractured humerus, had fractured ribs, had a fractured femur, all different levels of healing. The kid was only 3 months old. And I had a feeling about this kid and what I saw. What is your job? Now, a mother brought this child in. I don't accuse anybody. That's not my job. What is my job? I want to take care of that kid and keep them safe, right? I don't want this to happen again. It's not who did it, why they did it. It's this child. I need to protect that child from further injury. So we did. What it came out to be is this kid was a twin. So we brought the twin in. The twin had the same injuries. And then they brought the 2-year-old in, and the kid was walking around on a fractured femur. Today, the person who did this to them no longer is involved in the life. That person is in jail. It was actually the father who had to stay home with the kids and couldn't handle it. And the mother was working 14 different jobs to try to keep food on the plate. So it wasn't the mother, and that's who brought the child in. So in cases that you suspect child abuse, make sure your goal is, and it's hard not to get angry and yell at the people who bring these kids in, it's to protect the child, okay? And I did follow up with that. In fact, one of my friends was the person who was in charge of child abuse in this county. So I was able to follow it up really closely. So these kids are fine today because of that. There's types of fractures. It's simple, the crack bones, and then there's these open fractures. Now, if you have a fractured and the bone punctures the skin, that's an open or a compound fracture. Now that bone has hit the air, it's infected. And our concern then is infection. These require IV antibiotics. They will be casted. They might have a window to look at that open area, but they will be casted and they will be on those IV antibiotics. Complicated, sometimes these are ones, the ribs go to the lungs. That could be a complicated bone. Communicated, which is these little bones, they go little pieces everywhere, and we have to line them up. Sometimes these require open reduction, internal fixation with plates and screws to get that bone straight because we want it to grow straight. We don't want a crooked arm or leg, even fingers and toes. Now, one of the things that happens to children is they fracture what we call the epiphyseal plate, which is the growth plate. And you could see by these pictures where the growth plate is. It's that one that goes into the joint, okay? What happens if we do not fix these properly, that arm will, or that leg is not going to grow like the other leg. And if it's a leg, we don't want on one leg shorter than the other, because then we'd have to use, different sort of shoes. They'd be limping, create back problems. We want them to grow. So what do? When we see it's in the epiphyseal plate, we will do an open reduction. This means surgery. Again, lining it up, plates, screws, put it in good position. So as it grows, it's going to grow normally. Now, the one thing that amazes me is how quick children heal. Look how quick those young children heal, 2 to 3 weeks. That's why if we're doing casting on children, it's not long. I mean, those young toddlers that break their bones, it's 4 weeks casts are off. And then a little bit older, it could be up to 8 weeks, but adolescents and us, it could be 3 or 4 months for that bone to heal. So the younger kids heal better than the older kids. So you get a kid who fell off the monkey bars, complaining of pain in the wrist, and you see some swelling going on there. What we're going to do is do an x-ray and we're going to look at it. Now, usually the parents are going to talk for the kids and they're going to tell you what they did. I also want to ask that kid somewhere along the line without a parent, so how did you fall off those monkey bars? Did it get slipped and your hand just get lost? What happened? And especially after I've opened up that, my rapport with these kids, getting on their developmental level and making sure those stories match. And the only reason I'm doing that again is to protect the child, because not all fractures and stuff are from monkey bars. It could be abuse. And you always have to protect your child. Don't put any point fingers, no blame. I mean, it happened. Kids do this. This is what kids are made to do. They fall off things, they break bones. It's okay. But I want to make sure that they did it and it wasn't an abuse thing. What is our goal? Well, we want to get that fracture lined up. We want it to function fine, and we do not want any deformity left because that the bone wasn't set correctly. Now, we put on casts, right? And we send them home. We need to teach parents, or if they're in the hospital, we need to be assessing them. We need to say, so how is your pain? It shouldn't be getting worse. It should be staying the same or getting better. It's getting worse and they tell you, oh, it feels swollen, it hurts more, my fingers are numb. And then you look at the capillary refill and your fingers are white. They're not even pink anymore. Something's going on. And if you see this arm, it's all black and that looks like so extreme. Well, it is extreme, but that could happen if we don't teach the child and the parents what you need to look for in case they have a cast on their foot, their arm. We want to make sure that they can move their fingers, that we have capillary refill or we have a pulse, and this is the teaching that we need to teach them, the 6 Ps. Now we put casts on. There's these orthopedic techs. There's these pediatric orthopedic techs that put them on. If you look at this girl, this is what we do in pediatrics. This girl likes pink and green. So we not only put it for her, we put it for her doll too, because it makes it feel less threatening. Many boys want to do the colors of their football team, their basketball team, or soccer team, whatever. I mean, right now with what's, football, soccer going on, they might want those colors on their cast. And pediatrics does have them. There's yellow, there's red, there's orange, there's 2 blues, there's 2 pinks, there's black, there's army, there's rainbow. I could go on and on. Depending on the supply, kids can choose it. And when you could choose a color, you know something, it's not as bad as a white cast, right? Because now you're cool if you get double colors. You know, it's like, all right, I can deal with this. And then remember, kids don't have to have it on that long. It's not like the older people. When they get home, they need to know to keep that cast dry. We have these bags that we give to them for the arm or for the leg that we send home with their sizes, and they take a bath or a shower, keep it dry. Now, I had one boy, he had an arm broken, his wrist, both of the bones, the radius of the ulnar, had a cast put on, went home, put his bathing suit on, and jumped in the pool. So now he has a wet cast. So the mother had to bring him back in. We had to take the cast off. We had to put another one on. Well, he did it again. And I'm like, you know, you can't do this again. Your poor mother, because they have to go through the whole process of going into an ER to go and get the cast removed, et cetera, et cetera. So teaching them, if it gets wet, it's dangerous. Remember, nothing stuck down cast at all. Maybe a hair dryer, right? Now, sometimes we don't put casts on. Sometimes we have to do some sort of traction. Now we have skeletal and we have also skin traction. Now, skeletal is when we use like little sticks in the head for halos, or sticks in the legs that we do with femur things. But we also have these skin, which this bottom picture here is called a Buck's traction. And what it does, it pulls the femur, it's for the femur break. It pulls the bone and lines it up, because when it's separated, those sharp edges go into the muscles and create bad spasms and pain. And once it's pulled out, the pain goes away. So it really helps until the child can get to surgery. So it immobilizes it, it prevents fractures. And here's two types of cervical traction. We have the halo, you know, the tongues going on, and then we have the other one that goes around the whole neck. Now, these have little pins that go right into the head, and pin care has to be done. Again, what sort of pin care? Depends on the doctor. Does the pin want care by the doctor, just soap and water? Sometimes that's all they want, or just keeping it clean, wiping it off with just water. It's up to the physician and us to look at it to make sure that those little sites are not getting infected. Here's some other type of tractions. We have the Bucks, like I just said. It pulls the leg. If you notice, there's a weight that's pulled. That weight must be on there 24 hours a day. You can't take it off, because then the bone will dislodge and create pain. You don't want to do that. We need to document the weight, how much is in there. And of course, we need to monitor those neurovascular signs. That big femur bone could have ruptured a lot of vessels in there, and it could include blood flow. So checking neurovascular and pulses of lower extremities is very important. Russell's traction is another type we can use. Again, keep that weight free hanging, leave it alone, let it hang there. And then like this one little girl here with her legs up in the air, this could be used for some hip dysplasia. You know, putting those legs, the balls of the hip joint back into the sockets, and we could use it by that. And then there we have the cervical halo traction. Again, usually that's when they do cervical surgery, C1, C2. There's some surgeries there, or sometimes they break the area, hold it still to prevent issues. Sometimes we have a kid for whatever reason, and one of their extremities could be their leg, could be their arm, one of them shorter than the other, and we want them to be the same size. We can put on what this girl has on her leg called an external fixation device. And what they do is they cut the bone, put the device on with a space in between, and the body naturally will form like a scab of bone. So it will make the bone longer. And it takes some time to do it, but we do that in many cases when there's like a really severe limp on that, because there could be so many issues with having a shorter leg. or even an arm. Amputation, sometimes kids are born without bones in their lower legs. I had a friend whose daughter was born without a fibula. So all she had was her tibia. So there was no support. So what they had to do at this time, maybe it's different today, I don't know, but they had to do a below the knee amputation. I met this girl when she was 5 years old, and she chased my children up and down the stairs around the house with her prosthesis, trying to beat them over the head. And she was the happiest girl I've ever met. And she didn't care that she didn't have a lower leg. And my kids didn't care either. They were just trying to get away from her so they didn't get walloped over the head. I mean, she didn't hurt anybody at all, but you know what I mean. She was very adjusted to it. Sometimes we have to do amputations, whether it's medically like adults, an infection, bad break, crush injury, couldn't be saved. We do have to do amputations. Again, remember, we need to remember the phantom pain, treat them for phantom pain, and get that stump shape so we can put prosthesis on. Children are competitive, and there are children who love sports. So many kids like to get up and go and don't stretch, and it can cause a lot of problems. Also, they're pushing themselves to the limits because they want to win, and all of these things can cause injuries. Making sure kids have proper equipment for sports is very, very important. Helmets and, shin guards and proper shoes and etc. What do they need for this sport to protect them? Overuse syndromes, children today, they could be in gymnastics or into swimming, and they keep doing the same movement, the motion over and over and over again. And this could cause problems, with their ligaments. So we need to be watching for that. And, if a kid's complaining, to give them that moment to rest. I mean, you see this with kids that are trying to go for Olympics, or they're in competitions, they keep doing the same thing repeatedly. So just remembering that, don't keep doing the same thing, you have to alternate. Now, I've mentioned hip dysplasia. It's also called developmental dysplasia of the hip, or DDH. And this is when the hip socket and the ball and joint of the femur don't match. They're born upwards somewhere, it's usually upwards. And usually you see this with girls. Now, what you see when you look at these children is one leg, because the hip is up top a little bit, one leg is shorter. Also, if you look at their buttocks, you'll have the crease higher. The gluteal folds will be different, okay? You try to do the ortolani, you can hear these clicking sounds. Why do you think a pediatrician takes their legs and move them in and out at birth? They're trying to make sure that is the hip in the right place. Now, if we find that the hips are out of place, the earlier we can start, the better they do. Remember, kids, their tendons, etc., they heal quick. So we need to not let that kid sit the way it is so it gets stiffer. We need to immediately get them in a Pavlik harness. And this is a picture of it down there. And it's simple to put on, and it's on for 23 hours a day. You only take it off to bathe them. What it does, it causes abduction of the hip, okay? So it puts that hip, tries to put that ball and socket back where it should be. Most of the time it works. Sometimes it doesn't do the way it should for whatever reason. So they'll put the child in that spica cast, which is that big plaster of Paris thing from their hips down their legs with the bar in between. And then if we still can't get it in, they might have to take the tendon and put a hole in it so that it can stretch, so we can get that hip back into the joint where it should go. But it's really hard, and it takes a lot of therapy afterward. One of these congenital deformities that we can have is called clubfoot. Now, you don't need to know the 4 different types. It's inwards, it's outwards, it's up, it's down. It's just the foot is not in the correct position the way that it should be. So remember, they heal quick, right? So as soon as possible, what we'll do is what we call a Ponseti method. And what we do is put casts on these children's legs and put these feet in the position we want it to go. Now, we change this cast every week, because they heal that quick, right? So we can't get it in the right position all at once, but we can put it where it should be in several different castings. Now, once we get those feet and ankles where they need to be, they do need to be monitored throughout their growth to make sure that their feet are doing the right thing. They need to go to orthopedic. It needs to be looked at. And every month it's done. And these children with these casts, I have seen them, actually a kid this size with a parent come in with one of the casts in her foot, in her hand, and the kid in the other side. Somehow this kid got out of this cast, and that was put on Friday, Saturday morning, and there's the cast. I said, how did that happen? I don't know how that happened, but these kids can be Houdinis. So if they come out, they do need to be replaced as soon as they possibly can. So the goal is to get their feet back where they need to be. It should be a weekly visit, a weekly change, and then they are going to be needing to be followed for their growth time, which is as a child, at least yearly, going to orthopedics to look at it. So osteogenesis imperfecta, this is the one that I told you, brittle bone disease. We don't know why it happens. We know there's some hormone, some hereditary component to it, but these children's bones are fragile. You can imagine, if you don't know this kid is what we call OI, osteogenesis imperfecta, can you imagine a vaginal delivery on these children? How much breakage could occur? Could the scalp, could be clavicles, could be humerus, ribs, hip, the whole thing, just trying to squeeze that child out. So that's probably the most dangerous time for these children. But the kids, what is our goal with these children? Well, we know these kids are going to end up in a wheelchair because of the amount of breaks that go on. They're going to be chronically in pain. And it's very difficult to try to correct all of these deformities on these kids. I mean, you might have 16 breaks at a time, depending. So trying to keep them in a position where they can get into a wheelchair. At least they can be mobile, right? We don't want them stuck in a room because many of them are alert in the brain, okay? So we don't want to do that. We do give some intravenous bisphosphonates therapy. We think it might help, but we have to be very careful and very gentle with them. And these children, physical therapy would be very, very gentle. Leg calf birth disease. It is an aseptic necrosis of the femoral head. So the femoral head, the ball that goes into the hip joint, somehow stops getting a blood flow to the head, and there's no infection, but the head of the femur starts to just go away. These children are usually males, 4 to 8, and it's all of a sudden these kids start limping. It's almost like juvenile idiopathic arthritis, okay? All of a sudden they start limping. They're stiff, they're sore. So it's one of the things actually they do rule out at the same time. But they do the x-ray and they see the fuzzy head of the femur and they're like, okay, this is what it is. So how do we take care of this? Once we do therapy, which is bed rest, okay? No weight bearing, maybe pull it with some Bucks traction could help it, and NSAIDs, anti-inflammatory, right? For the pain and the inflammation, usually they do okay, and it turns around and they're fine, and their femoral heads are fine. But it is not an infection, doesn't need antibiotics, it just needs rest. Now there's 3 different curvatures of the spine. So Kyphosis is also called humpback. This is what I would be calling it, looking at it. But it's the thoracic spine as a hump. You see this a lot with older people, right? But kids can get this too. Lordosis is L lumbar, L lordus. It's the lumbar, it's an inward, so you sort of arch backwards. You know, there's one of the muscular dystrophies that's, you'll see lordosis, and that's the Duchenne muscular dystrophy. We're going to go into that for a little bit. But these children, again, it's the lumbar spine. I mean, how do we correct anything with the spine? It's usually just through exercise, strengthening the muscles, trying to get it straightened back up. Scoliosis, most common. This is the one where you have an S shape, scoliosis, S-shaped spine. Sometimes we're going to see it, you know, at birth and they're younger, but many a times you're going to see it during that pre-adolescent growth spurt. Remember, they grow 25% of their growth in that 2-year period. So all of a sudden you see a shoulder up and one down and a hip up and a hip down and this little limp sort of thing going on. So what do we do? How do we treat this? It's a curvature. Well, we need to put them in a brace, just like these things down below. Sometimes they put nice colors and designs. Sometimes they're just basic white, you know, depending, you know, of course, it's money, how much they cost, right? But we keep these on 23 hours a day. They can take it off the shower and put it back on. Now, scoliosis tends to push the spine over into the lungs. This is when it gets to the problem where surgery is needed. If it's pushing against the lungs and not allowing the lungs to oxygenate, then we have a problem. Somewhere greater than 40, 45, you'll see two different things, 40, 45. If it's greater than that, this child will need surgery. Under that, we treat it with bracing and exercise, strengthen those muscles. My daughter's best friend, in fact, it's my other daughter. I met her when she was 3 and she's 30 something now. So she is like my other daughter, had scoliosis. She had the brace and she did the exercises and she's pretty straight today, but you have to keep up with it. If we do surgery, it's called a Harrington rod, and they take a rod and connect it to the spine and try to make it as straight as possible. Now, it's not going to be perfect. You can't completely straighten it, but it will be at a better angle for the child and for the lungs. Osteomyelitis. Osteomyelitis is you could have stepped on a rock or a branch, a twig or something. Let's say it's your toe. A lot of see toes and fingers with osteomyelitis. I see that a lot. And it somehow got the infection up and now the infection is in the bone. This usually starts with a little pain, and then all of a sudden it's the redness. Then you see the red streak going up. Then they start with fevers and chills, and then you take a CBC, white counts are elevated. That's the leukocytosis. So we can do biopsies, x-rays, we can look for it, but what is our treatment? So it's only in that place, but it is painful and it's creating havoc on the body with this infection. Usually it's due to a staph infection. So most of those staph antibiotics, vancomycin, amikacin, gentamicins, all the sins, remember this is the aminoglycosides. We have to be very careful with renal function and hearing. Those are the two things it affects. So what does that mean for this patient? Well, we're going to have to monitor lab values. We're going to monitor peak and troughs because we could stop hearing, we could kidney failure if we're not doing it that close. Osteomyelitis, we should have these children on bed rest. Keep that limb wherever it is immobile. Take care of the pain with it. Long-term IV antibiotics. It could be 3-4 weeks or it could be several months, depending on how resistant it is. For nutrition, these children need high protein for muscles, right? And bone. So that's what we would do for that. And again, they're immobile. So keep them interested. They're going to be not at school. They're going to be home getting their IV antibiotics. Now, we've talked about cancer, but this is another cancer of a bone. It could be a scapula, could be a jaw. So femur, tibia, ulnar, any of the bones, right? How do we treat other bones like osteosarcoma? Well, radiation, chemo, and then we take out the bone. That is the best outcome. And of course, if it's not metastasized. If it's metastasized, we know that's going to be harder to take care of. JIA, I've mentioned it. It's juvenile rheumatoid arthritis, which is a new name today. And it's when the body attacks the joints. I mean, I'm so familiar with it because finally, after 8 years of trying to figure out what I had, they finally figured out, yeah, I've got rheumatoid arthritis. So in children, it's usually the young ones. Again, how do they present? These children are limping, or they're complaining of stiffness. Their hand hurts, their knee hurts, their shoulder hurts, something hurts. It's just not right. And they continue to complain about it. You'll see that morning stiffness. You'll see difficulty walking, maybe a limp. You might see swelling. And then the other thing that's missed is uveitis, which is you'll see redness in their eye. Children with JIA should be getting yearly ophthalmology visits to look at their eyes to make sure they're okay, because it can affect their sight. Now, diagnosing it is the hardest thing. Like I told you, 8 years it took to diagnose me. Finally, they came up with this test called a CCCP. I don't know what all the initials stand for, but they did that with an RA factor. The CCCP should be less than 50. Mine was greater than 250. And then, of course, the RA is positive, negative. It was positive. So finally, they're not fibromyalgia anymore. Yes, I am a real RA person. So what do we do and what do we see? Well, when we're having these flares or these exacerbations, what do we see? Remember, this is an attack on your joints. There's inflammation. So the lab tests we look at are things that look at inflammation, sedimentation rate, right? We're going to see that CRP, which is the C-reactive protein, also shows it. Also, elevated white counts can also show you some sort of inflammation is going on, and it can tell you how we need to treat it. Now we know there's no cure, but what our goal is to preserve function, to prevent deformities, and try to keep this child as pain-free as we possibly can, because it hurts, especially in flares. So NSAIDs are the pain management of choice. We're also going to put them on these anti-rheumatic, Humira, Cimzia, Enbrel. Those are the injectables, or it could go into an infusion, Remicade, or I could go on, Orencia, Actemra. I've been on all of them. They're still trying to find mine, but these are things that are put on to try to decrease the body from attacking the joints, to decrease the pain. And usually they'll do it in combination with methotrexate. They use corticosteroids usually for flares. They don't like to keep them on a long-term corticosteroids, because what do corticosteroids do? Weight gain, Cushing syndrome, and puffing up. They don't want that with RA. So again, keep the body moving. Swimming is great down here in South Florida. Trying to keep them as healthy as possible. They can use heat, exercise. I don't like heat. I like cold. So ask the child what they prefer. Could be cold or heat. It doesn't matter. Whatever works the best. And let that kid know that it's okay. We'll help you. And, they just need to stretch, and they can be normal children as long as they do what they're supposed to do. And if they hurt, tell their mommy, tell their daddy, so they can get a pill for that. So they're not going to hurt as much. Now, JIA attack joints. Lupus attacks all the body organs, okay? It is more common in girls and women. This is your pre-adolescent, 10 to 19, that we usually see it. African American, Asian, Hispanic, and maybe it's due to puberty. That's a hormone thing. They don't really know. I mean, I wish they did. We do know that stress, infections, some exposure to things can create more of like a flare going on. And me, who lives in South Florida, overexposure to sunlight. So having these kids with some sort of sunscreen and limiting time in the sun is very important. They have that nice little red rash on their cheeks. And if they're going into a flare, we can see it occurring by these signs and symptoms. They'll start that nausea, vomiting, the diarrhea. They can have pain that looks like RA, okay? They can have those joint pains that go on. And then all of a sudden they're getting forgetful. You start seeing seizures or that chest pain, pleurisy. We know something's going on. The heart's being attacked, proteinuria, the kidneys are being attacked. And at that point, you know, it's the corticosteroids and monitoring them closely to get these children more under control. Again, our goal is to have them under control, have them be able to deal with life and stress. Of course, take care of that sunlight, don't have too much with it, especially here where I live. And, you know, make that kid be as normal as possible. Elvira, do you have a question?
Yes, please. Okay, so why would we give them corticosteroids that would lower their immunity if their body's already attacking itself? Or
Because
lupus?
because it's inflamed. Your body's inflamed. And actually, they give these kids steroids daily. Steroids and folic acid. They might add Plaquenil or one of those other drugs, but usually that's the treatment for lupus. Yes, I totally agree with you. It does. It lowers your immune system. It gives you more susceptible to diabetes. It lowers your infection and healing. Yes, you're absolutely right. I know. I've been trying to figure it out too.
Since I have lupus, can I speak to this one?
Oh, please go for it. I love it. Go.
So the main thing with this is that your body's immune system is overreacting. So you actually want it to be somewhat immunosuppressed. You have to be careful because you can get sicker, but this is your body's immune system attacking itself. So you have to suppress it, or you're going to be totally screwed and not be able to walk. At least
Makes sense. So the intention is to basically, yeah, slow the immune system. Gotcha.
At least that was my understanding from my my rheumatologist. So.
You know, that, yeah, absolutely. Absolutely.
Thank you.
Sorry for jumping in. I was like, oh, I'm an expert on this one. I know this.
No, I totally appreciate it. As I said, I don't mind any student stopping me, asking questions, or, you know, you have, you know, I have my RA, I can speak to that. You have lupus, so I appreciate that. Thank you very much, Mary. Appreciate it.
Thank you, man.
Okay, Kirsten, 10 years old, sustained a fracture in the epiphyseal plate when she fell out of the tree. When discussing this injury with her parents, the nurse should consider what? Well, what's an epiphyseal plate?
Bone growth can be affected.
Absolutely. It's all about bone growth. Good job. Okay, let's get into neuromuscular. Now, neuromuscular, we think CP. It's all about something that's going on in the brain and the muscles don't respond to what the brain wants it to do. It is non-progressive. It's just is what it is. It's usually it's in the development, but I've also seen it happen with prematurity, hypoxic or anoxic episodes right before or during birth that can also cause it. It is abnormal muscle tone. They can't take their hand, some of the more severe, they can't make it go to their mouth. They just don't have, it doesn't connect at all. Now, causes something to do with the brain, some gross abnormality. Vascular occlusion causes what? Lack of oxygen, some sort of low birth weight, anoxic, hypoxic. All of these things can cause cerebral palsy. Now, when we're looking for cerebral palsy, you know, premature infants are followed the first year of life very closely to look for these sort of things because we want to institute early intervention. Your speech, your physical and occupational therapy is absolutely what they need, because the earlier we catch it, the better they're going to be in the long run. Because we know infants, they'll just do what you want them to do because they don't know how to say no yet, right? So we want to start it very, very quickly. We're also going to do metabolic genetics testing because we want to see if there is any correlation to that and the cause of the cerebral palsy. So one of the most common of cerebral palsy, and when you think about it, is called spastic cerebral palsy. This is that hypertonicity, poor posture, and difficulty maintaining balance. Many of them don't walk. Many of these children are in wheelchairs. You know, when I was doing my doing the clinicals for my students for Fortis, they send them to this prescribed pediatric daycare. Well, my little guy, Jonathan, my favorite of all, little 7-year-old boy, spastic cerebral palsy, nonverbal. Let me tell you, he'd see me across the room and this smile would go ear to ear and his big white teeth would start and his hands would go, and he was getting ready because he knew I was going to come up and give him a big hug and a big kiss. And he's just, he can't speak, but his reaction, priceless. Now, they did give him a pad where he can touch it and he can talk. So he could talk to me a little bit. I mean, not, you know, big things, but I knew that that kid knew when I was there, and he knew I was going to go and tickle him or do something with him, spend time with him and clap hands when we were doing videos together, whatever it was. They're teaching cerebral palsy, and he's severe nonverbal with a G tube, can't even eat in the mouth because even his muscles in his mouth don't work. You'll see any level of gross fine motor delays. Remember, there's mild cerebral palsy and then there's quite severe. Jonathan was upward to the severe side. We know it's abnormal motor because they can't control their muscles. They have to be taught how to walk or to walk with a walker. And again, this is early interventions. This place where this Fortis College sends them is an amazing, amazing facility. The people there have got children doing things that nobody ever thought they would do. Again, why? Early intervention. Many of them go there from 2 months all the way to 18 years old. Yes, and it's amazing what I have seen there. These kids don't sit right. You have to hold them up. They have to be strapped in and belted in because they're just going to slide out of chairs. But you know, these kids are amazing. Now, the milder kids, like this kid does have some braces on his feet, so to help him to pedal. But you know something? Isn't he mobile? He can get around. And that just makes the child very happy. Could be in a wheelchair that they have their finger that they could, you know, move that motorized thing around, that they get that mobility. As they're aware enough, we will give them those chairs to be able to do that. So these kids need to be social. They need to be around other kids and they need education. You know, I started working with children with cerebral palsy and cognitive delays when I was a teenager. Probably why I, in the end, gravitated towards the pediatric population, because I started out in adults, because there wasn't a lot of pediatrics where I first started my nursing career. But I'm telling you, these children used to be just brought in, they would feed them, get them, bathe them, get them out of bed, sit them in a chair, you know, maybe brush their hair. You're just typical grooming, you know, but they put them in front of a TV, but they didn't teach them. Today, Jonathan does speech therapy, occupational therapy, physical therapy. He's doing more than ever. He's learning shapes and colors. And I think that's amazing that these kids that they thought, he doesn't talk, except put him in the corner. No, this kid is the sweetest and he's funny and he doesn't talk. So, and this is all because of early interventions. They do, as I said, they put ankle braces on them to help support and hold their muscles for them. They do things like Botox. They put them on the carbidopa levodopa, which they use for Parkinson's disease. What is that? Spastic. It's like a Parkinson, right? And in Jonathan, he was put on it, and it helped decrease it some. Dental hygiene is so important. These kids, especially Jonathan, he doesn't eat, but his teeth, that chewing and stuff that he gets, he needs his mouth clean at least morning and night. And you can see like slime build up on it. You know what I mean? This is the cerebral palsy children. And again, therapy, therapy, therapy. Prognosis depends on how severe. There are some mild of these that can be taught how to do things. They can have jobs, maybe live on their own, who knows? Just like some of the Downs children, right? Yes, they can. But there's some severe that, we know that they're going to need help for their lives. Again, as nurses, make sure that these families have all the services that they can. They know how to give the medicine. Safety, these kids, they'll fall out of beds. They need to be strapped in, belted in. They're Houdinis to get out of everything. And give them some fun things to do. This kid, I remember one day I was at the daycare with my students, and they put these pools all out in the backyard. And they had kids, some inside the pools, some with their feet in a chair splashing around. They had Jonathan in the middle of the one with things squirting on him. And I'm telling you, this kid was so happy. Give them something to do, make them have fun. And these kids actually do really well. Now, I've mentioned myelomeningocele. It's a type of neural tube deficit. You've heard that word in pharmacology, right? Prevent neural tube deficits, get folic acid. We should take it before we become pregnant. Well, this is a neural tube deficit. It's the spinal column. The meninges and the spinal cord are on the outside of the body. Just like I was talking about the stomach, gastroschisis on the outside, and bladder exstrophy on the outside, right? These are things that can happen. These children, again, we're going to be taking care of infection control, right? Because we don't want infection to go in the meninges, spinal column, right? And they will be on their abdomens. It's the only time that they don't go back to sleep on supine. They need to be on their tummies, but they have to be monitored with a cardiac monitor and also with an O2 sat monitor to make sure that they don't have a SIDS death type thing, right? Now, why does this happen? Well, they think maybe it's that folic acid thing, could be part of it, could be genetic, but it could be maternal obesity, diabetes, could be low B12. Now, this meninges and spinal cord had to stretch to come up and go out of there. So it's from the lower extremities, those nerves had to stretch. So you're going to see some sort of decreased sensation in lower extremities. There could be minimal deficits to complete deficit. Because those nerves were stretched, you need to be very, very careful to make sure that they are urinating. Many of them need to be catheterized every 4 hours. That's why they're under latex allergies, because we don't want those latex gloves in them all the time. Plus, they're going to have surgeries on their back. So they're being exposed. So today, immediately at birth, latex allergy. Have never touched it, but latex allergy. And also, because of that lower extremity nerves being stretched, you must monitor their bowel habits. They can become constipated, impacted, because they can't push. They don't have nerves to do it. So urine and bowel control are some of your priorities in watching these children. Now, one of the other things that these children get, because that tube was interrupted, and that cerebral spinal fluid, that fluid that goes up and down, sometimes it gets stuck, and these kids get hydrocephalus. So these children might have a ventricular peritoneal shunt because of that movement of fluid was interrupted. I've already said folic acid, 0.4 milligrams a day, because everybody knows right before they're going to become pregnant, a month before. I didn't, but Yeah, okay. Wernig-Hoffman's disease. Now, this is a muscular dystrophy. Wernig-Hoffman is an autosomal recessive, so it's passed on from the parents. It's also called floppy infant syndrome. And this child is extremely hypotonic. At birth, they look okay, because remember, at birth, everybody's hypotonic. Even in the newborn has no neck control, right? Well, now the kid's 2 months old and still don't have any neck control. Now you start to look. These kids at birth are able to suck, and then all of a sudden they're not able to suck anymore. And it progresses, 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 and they usually die by age 2 years old. Respiratory distress, gone. And there's nothing we can do for it. So probably of all of the muscular dystrophies, this is the one I think that's absolutely the saddest. Duchenne muscular dystrophy is that one muscular dystrophy that I don't know why, but all of your exams love to quiz you on this one. Your HESI, your NCLEX guaranteed is going to be there. Okay. It's called pseudo hypertrophic muscular dystrophy. It is the most severe and most common of all your muscular dystrophies, and it comes from X-linked recessive, so mommy passes it on. It is boys, ages 3 to 7. What do we see? Well, initially, they're fine, and they're moving, and all of a sudden, about 3 years old, you're going to start to see their calves are going to start to get really big. And you're gonna, because they're like always tense, okay? So they get these big calf muscles and they're gonna be falling. And you're gonna see progressive weaknesses going on these children. As they grow, these children, because of the weakness, you are going to be instituting physical therapy, occupational therapy, trying to keep those muscles moving. It ends up they're not able to walk, they end up in wheelchairs. We're concerned about obesity in these children too, because of lack of movement. And these kids will eat normally, but they do have some mental impairment. So they eat and they become big, with obesity, and then it's hard for their muscles to work, right? It's heavier, it's extra weight, they can't move around. So you've got a kid who's falling, you see them waddling, trying to walk. Then you see them get up off the floor and their hands crawl up their legs like I do. I'm on the floor. How am I going to get up? I'm going to put it on my knees and I'm going to move myself up. That's Gower's sign. And of course, that lordosis, like I said before, that lumbar inward curvature. See that big arms, those big legs. And what do we do to diagnose these children? Well, we're suspecting. When we see these signs, they're very classic. We're going to do what we call an electromyography. It's also called an EMG. And this is a picture of it. They can use little needles or they can use just little, those stickers, put it on. And what they do is they shoot some electricity and it makes the muscle spasm. And they look at how quick it reacts and how strongly it reacts. And according to that, they can make that diagnosis. Now, the one thing I'll tell you is once that child comes back from an EMG, they're going to be uncomfortable. So make sure that we give them some Tylenol or Motrin or something. They don't need anything more than that, but it does hurt, but it's temporary. So there's really no treatment, so it's sort of sporadic, but again, it's those therapies, keeping them moving, keeping range of motion going, and let them try to be as normal as they possibly can with exercising and bracing. And, sometimes these children, parents want to have more, right? So this is X recessive. So getting genetic counseling for that family, because if they have another boy, chances are this kid's going to be muscular dystrophy, the Duchenne. So it's hard enough to have one child going through all these therapies. To have two would be a lot for any family. Guillain-Barré. Guillain-Barré is a condition usually follows an upper respiratory, so a viral sort of thing. And all of a sudden, it starts from the feet and it works upwards of the body. So it's called ascending. So the feet all of a sudden get a little numb. You start to fall, waddle. Then all of a sudden you might become incontinent. And these could be older kids that shouldn't be constipated because you can't push because the nerves are deading. It's infectious polyneuritis. All the feelings are going to go away. Then it moves upwards and it hits the phrenic nerve. And the phrenic nerve is dead, doesn't work. If you don't have a phrenic nerve, doesn't work, you don't breathe. So nursing, priority care, monitor respiratory function on these children, especially if we know that it is a Guillain-Barré. Another thing, just like the myelomeningocele, be careful. Urinary retention, constipation, that might be your alert to this is what's going on with these kids. So how do we treat it? Well, if they need a ventilator, we give them a ventilator. We intubate them, we give them a tracheostomy, whatever they need. Of course, whatever nutrition, the way we can give it will do. But the treatment, intravenous immunoglobulins, maybe steroids. It's not really said if it does or doesn't work. Sometimes plasmapheresis, we try to remove things from the blood, see if it works. But IVIG is the mainstay of treatment. And who knows when the feeling's going to come back. Now, these kids are ventilated. And there's usually a rate on the ventilator. Let's say it's 20 times a minute. All of a sudden, you might see the child take a breath. In between the other ones, that's a spontaneous respiration. What does that tell me as a nurse? It's starting to go away. And the child will start breathing more and more and more by itself. And then it goes back down, descending. And then these children usually require some physical occupational therapy when they're done because their muscles are weak. We need to prevent those muscle wasting on these children. And the kids come back and usually they're fine. Usually, if they're in the hospital and there was no hypoxic episode, they're fine. Tetanus, it's called lockjaw. This is like stepping on that rusty nail, right? Lockjaw is right here in the neck, the muscle spasm. It's like extremely painful spasm. And you can't swallow, you can't breathe, you can't open your mouth, and it hurts. So these children end up on a ventilator. These children are extremely ill. What we need to do is give them the tetanus toxoid vaccine, and we need to just monitor them closely. They do give them some muscle relaxants. And basically, they paralyze them like if you went to surgery. And they try, because that muscle is so tight, so painful, they try to relax them. And what we'll do is wherever they got the tetanus from, we'll wash that wound and clean it, and we'll give that immunoglobulin therapy, that tetanus immunoglobulin, and we'll watch them very, 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 very closely. Very sick kid. Botulism. This is from improperly sterilized foods. Maybe you can your own foods, jar your own foods. I used to do it up in New York. I used to take the tomatoes and we used to put them up for the winter. So we'd have fresh tomatoes for spaghetti sauce or whatever, right? Well, if you don't clean those jars well, it could carry the botulism. Now, one of the things some cultures believe in is if an infant is constipated, you give them a little bit of honey or a little bit of Karo syrup, whether light or dark, and it will help them pass their stool. Problem is, was that honey or syrup, was it sterilized? Was it pasteurized? How long has it been on the shelf before you even bought it, after you bought it? And it could have botulism in it. Again, it goes into this respiratory thing going on, life-threatening respiratory paralysis. Again, what do we give? botulism immunoglobulin. Again, watching the respiratory status, and we will keep them intubated until, again, it dissipates and they start to breathe. Spinal cord injuries, working in a trauma center ER that I was the last 10 years, I've seen a few. I've seen falling off a second story balconies of a 3-year-old. I've seen that. I've seen, and the one that always will remain with me is a 16-year-old boy on a Saturday afternoon playing baseball, slid into third base. His head hit the knee of the defender, and the stands heard a crack. His cervical spine, C5, C6, should be straight, right? It was angulated. It was quite intense, almost broken. This kid presented, right leg could move his little toes a little bit, left leg couldn't move anything. He came on a backboard and his neck brace on. That's a sports injury, but it can happen any different way, whatever the injury is. So what do we need to do? Now, this is a 16-year-old boy that cracked his head with all this neuro deficit already on the primary nurse. My job is that immobilization and to make sure I keep that area immobilized to prevent further injury. That child went for a MRI under my watch from the emergency room. It's the only one I've ever done. But because it was so angulated, there was so much neuro deficits, we did it to figure out what we needed to do for him. So making sure we kept that stabilized was the biggest thing we could do. There was neurosurgeons, general surgeons, x-ray techs there, lab techs there. I can tell you that there was 40 people in that room, and the 16-year-old, my job, keep him calm, keep his neck immobile, and I went to see him 2 weeks later. I brought him up to that pediatric ICU that night. They put tongs in him. They put him on a cooling pad with some steroids, prevent inflammation. And the next day, he went into surgery. 2 weeks later, I went to see him up in his room. He had some minimal numbness in his left leg, but the right leg was fine. He was going into rehab. 1 year later, he came to visit. Walking, he was perfect. Why? Kept the neck immobilized. And I wouldn't let anyone touch this kid. I was sort of mean and nasty, actually. And nobody's going to hurt my kid. So a progressive infantile spinal muscular atrophy, and the most common paralytic form of floppy infant syndrome, is which one? Werdig Hoffman. That's the little frog guy. Poor little baby. So that's what I have with that. Any questions? Anybody want to win the Cahoots today? That's you, Darcy, right? I see you there. I think there's 39 questions today. It's not that bad. Week 9, 3 more weeks after this, guys. It goes so quick. And a multi-select, your favorite. What is a priority for a nurse to assess following a cast application. And not only for you to assess, what are you going to teach that child and the parents? Pulses, pain, movement, and sensation, all of those, all the above. Absolutely. I mean, if you can't move it, something's going on. Probably there's swelling, too much pain. What should the nurse monitor after a soft tissue injury? Remember, sometimes you just see this little ecchymotic area and you're like, it's just a bruise, right? Sometimes it can go really deep. Then what are you concerned about? Or what was the mode of injury? Was it a crush injury? All of those things make a big difference on how you look at it. And always check your neurovascular signs, and you're not going to have any problems with blood flow going to where it needs to go. A fracture that penetrates the skin is called an open or a compound fracture. That means a bone is sticking out of the skin. What is the priority nursing care of a child with a compound fracture? The bone is sticking out of the skin. What's your priority here? What are you worried about the most? You're worried about infection, okay? Infection is number one. So IV antibiotics. Now, are they in pain? Yes, absolutely. But your priority is to prevent infection. If it gets infected, it's going to be even in more pain. So IV antibiotics are your number one. What is a priority care for a child who fell off a second floor balcony? So whenever you have an injury that you know the neck, the spine has been involved, it's that immobilization. I mean, all the rest are secondary. Keep that spine mobile as you can. Prevent those injuries and be that 16-year-old that comes back to visit you to say thank you, because he did. He was so happy. Principles of managing soft tissue injury include what? And that's your rice. Rest, ice, compress, and elevate. Absolutely. Epiphyseal plate fractures in children may do what? Epiphyseal plate fractures. Say that 3 times fast. So remember, that's where the bones grow. We want it to grow accurately, and we don't want a shorter arm or leg or anything. So we want to make sure that we treat it, and we're going to do surgery, open reduction, internal fixation, plate screws, make sure it's in great alignment so that we get proper growth. What findings for a patient in skeletal traction indicate peripheral neurovascular impairment? And it could be a fractured femur. I mean, I had a boy who come in through the door. Parents carried him, his leg, he had fallen and the leg was swollen. He had fractured his femur. So what do? We set him up. First of all, what did I do? Okay, so I looked at it and I'm checking pulses, making sure that capillary refill, pulses are there. And in the ER, they actually put them into buck traction to get that bone straight, to alleviate the pain and those muscle spasms. A multi-select. How should the nurse care for the skeletal traction for a child with a fractured femur? Now you could do skeletal or skin traction for a fractured femur. So we always document the weight every shift, because people can come and remove it. A family can come. They don't know housekeeping. I mean, it has happened. So make sure that it's always documented. And of course, leave those weights free hanging. We want it pulling on it 24 hours a day. When caring for a 9-year-old in buck traction, what action by the nurse is correct? So we just want to make sure that there's blood flow, capillary refill, checking pulses, making sure the blood flow is going where it needs to do. Usually, again, buck traction is going to be your femur that we're usually trying to pull it. It could be that it's septic femoral head too, right? Calf purse disease. So we want to make sure blood flow is going where it has to go. A multi-select. Which assessment indicates an infant has developmental dysplasia of the hip? So when we turn them over, the butt cheeks usually have a fold. When you have the hip higher, those folds or those gluteal folds are going to be a little higher. So they're not equal. Also, that clicking, that ortolani, that's what we're looking for. Moro is a startle reflex. Bobinski is when you check for sensation in the bottom of their feet. It's one of the other reflexes. What position do you put the legs of an infant with hip dysplasia? What is our goal? How do we get that hip ball back in the socket? And it's called abduction is what we do for that. Very good. Remember, it is on 23 hours a day, only off to bathe. What statement by the parents indicate more teaching regarding their 2-month-old infant with a club foot? So remember, that's that Ponseti serial casting that we do. Trying to get those feet back where they need to go. So we know that we need put every week. Every month is too long. Remember, 4 weeks, those kids heal. So then you're going to put them in the wrong position. So you want them to start as soon as you possibly can. You want it every week, changing that. And as they grow, they do need follow up to make sure their feet are in the right position. They might need orthopedic shoes or something to keep those feet the way they need to be. 1 month, too long. You have putting those feet in a wrong position because they put them serially into where those foot need to be the normal way. A multi-select. Osteogenesis imperfecta. So it is called brittle bone disease, and those bones are going to be crooked. Remember, our goal with this is to try to keep the kid with all of these breaks and all of these fractures, try to keep them in a position where they can at least get up, get out of bed, sit in a chair. Because if they're laying down all the time, they're not going to be able to get up. And we don't want that immobility for any child. What is the pathologic cause of leg calf birth disease? It is an ischemic aseptic necrosis of the femoral head, which means there's no blood supply going. So the head of the femur is dying, but it's not due to an infection. So how do we treat it? Well, bed rest, NSAIDs for that pain and inflammation, and then we might put them on traction to pull it. These kids are stayed home. They don't get antibiotics. It's aseptic. There's no infection here. So it's bed rest. And usually, once we rest it, NSAIDs, these kids do well and there's no long-term injury from it. Kyphosis. So kyphosis is the thoracic spine. It's that humpback, as I call it. Lordosis is described. Remember L, lordosis. And remember, this is the one that Duchenne muscular dystrophy, you will see the lordosis is part of it. That exaggerated muscles of the arms and legs. So it's an inward curve of the lumbar spine. Remember, lordosis L, lumbar spine L. And scoliosis. Scoliosis S shape of their spine. We are concerned when it starts impeding upon the lung, up in the thoracic area. It will lung and squeeze it so it can't breathe the way it should. That's when we need to do something. So adolescents with scoliosis have up to a 45 curvature of the spine would need to what? Means up to that. What do we do for it? If it's more than 45, then what do we do? So up to 45, and if it's not bothering the lungs, it's not progressing, we can wear a brace and do that exercising, strengthening those muscles, because usually this is about that pre-adolescent time, right? So wearing that brace, exercising, will strengthen the muscles, and it will hopefully get that spine back straighter. What is osteomyelitis? So basically, osteomyelitis is an inflammation due to infection in the bone, right? And it is dangerous, and there's a lot of medicines that it requires. Goals for JIA include, you got a young kid, they're usually diagnosed somewhere between that 1 to 3 age, and they're limping and they've been diagnosed. They got a diagnosis. How are we going to take care of these? What's the goal? I mean, we know we want them to be kids, but we do that by reducing the joint pain and the swelling, and then they're able to be children. A multi-select. What might you anticipate for a child diagnosed with JIA? What would you look at? What do you know is going to be there? So we're going to look, are any of the joints disfigured? I mean, I got one finger a little bit. I mean, that's the biggest one that I have, which I'm okay with that. Probably the one that uses on the mouse the most, you know, with my computer as I teach. But it's difficulty walking, especially morning stiffness and that uveitis. Remember those eyes, and that's why we have to be an ophthalmologist once a year to get the eyes checked. A multi-select. What can help a child with lupus erythematosus prevent exacerbations? I mean, you could say this either with JIA, JRA, and lupus. There's very much similarities in it, but some of these are different in lupus, and that is wearing sunscreen, protecting from overexposure, prophylactic antibiotics and steroids, you know, are also needed for that also. You know, and preventing that stress, right? Because stress does cause flares to occur. What organs can lupus affect? And then I'll ask you, what organ doesn't it affect? It affects all organs. Any organ can be infected. Skin is one of the organs, all of them. What is cerebral palsy? It's a neuromuscular disease. And cerebral palsy affects the body movements and muscle coordination. The brain and the muscles don't work together. You want to do something and your muscles do not just not respond to it. A myelomeningocele. Remember to take your folic acid if you want to become pregnant. So it's the hernia of the spinal cord and the meninges. And remember, those nerves are stretched with that spinal cord. So you have to be worried about what goes on down below. Worry urinary, bowel, and sensation of the lower extremities. All of those will be affected. Infants with myelomeningocele demonstrate it's both motor and sensation. I mean, if you can't feel it, you can't move it, and you'll see that. Many of them end up in wheelchairs, but they're perfectly normal mentation. They will grow up in mainstream school and do really, really well. Myelomeningocele have decreased motor and sensations in the lower extremities. The nurse should monitor closely what? So we're worried about urinary retention. The nerves that go there have been damaged or stretched. Also remember the bowels, watching for constipation, monitoring that will help a child not get a bowel obstruction because they're not stooling, because they can't, they don't feel it. A key feature of Duchenne muscular dystrophy is what? Again, boys, ages 3 to 7, we usually start to see that deterioration about 3 years old. And it's this progressive muscle wasting. And usually that muscle at waste is the lungs and the heart stop, usually as adolescents. It's a long, hard battle with those kids. What is one of the procedures a child with possible Duchenne's may need to diagnose the condition? You know, and that's your EMG, electromyo, which means muscleography, and it stimulates muscles, seeing if they respond. Again, remember, this hurts. Somebody else is stimulating muscles, and it can cause spasms and pain. Make sure you give them something when they come back to the room after that, or tell the parents if they're going for an outpatient to make sure they have something. How is Duchenne muscular dystrophy inherited? And it's from mommy, X-linked recessive. Again, children with Duchenne's and parents want to have another child do need to go get genetic testing to see what's going on, to see if what's the possibilities. In caring for a patient with Guillain-Barré, the priority concern, your concern, you have a child diagnosed Guillain-Barré. What are you closely monitoring? Priority. Remember, this is all about nerve degeneration. Starts from the feet, works up, so it's ascending, going up. The phrenic nerve is a nerve, and it controls the diaphragm. Without it, you don't breathe. So the airway, number one, always, right? Airway, number one. For a patient suffering with Guillain-Barré, they would complain of weakness. That was what? So it's ascending, starts from the feet and it works up. And you'll see them shuffling, falling over, incontinent, constipated. Those things will happen on the way up. And remember, it's a virus, so antibiotics don't do anything. IVIG is your treatment, right? A multi-select treatment for Guillain-Barré. What else do you need to know about Guillain-Barré? We might give steroids, we might do plasmapheresis, but treatment includes IVIG and respiratory support. Again, this is not an infection. This is a viral thing that occurs usually after an upper respiratory. So antibiotics, no. IVIG, steroids, maybe. Respiratory support. You can always answer IVIG and always be right. What type of cerebral palsy causes hypertonicity and poor fine motor skills? That hypertonicity, that spasticity, right? My little Jonathan. And it is called spastic cerebral palsy. When you think of that cerebral palsy and the most severe of all, you think spastic. What priority action should a nurse take to a patient with a suspected spinal cord injury? Priority. What's your priority in a spinal cord injury? MNET, take care of that spine. Do not let that child get more injury because you didn't take care of that immobilization. You should get a tetanus shot. How many years? You know, in my career, I've seen many different numbers. 3 different numbers I've seen. What is it today? And today it's 10 years. And a couple years back, like 5 or 6 years ago, they started introducing diphtheria. So it is tetanus and diphtheria together because they were seeing an outbreak. So tetanus shot every 10 years, unless you had something stepped on a rusty nail or whatever, they're going to give you a booster. But 10 years is sufficient enough. It was 3 and 5 years of my career. What is a symptom of tetanus? Remember, tetanus is all around the neck area, swelling and spasming and pain and respiratory problems. Again, these kids are sick as sick can be. We give tetanus immunoglobulins to these children, support them with ventilators, big, strong muscle relaxants, and hopefully they'll turn around. Last question. Most common causes of spinal cord injuries are? And it's accidents, motor vehicles, we know that's #1 in pediatrics world, right? And of course, driving and or sports. And, you know, remember my guy who just slid into third base. Oh, by the way, he was safe. #3, Annie. Good job, Annie. #2, whoop, 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 whoop. Mia, good job. #1, almost the whole way through. Heather, good job, Heather. #4, Amber and Katie. That was a good one. Good job, guys. What I'd like you to do is sign your attendance attestations. Make sure you get those done. You guys have been pretty good with them. Usually by tomorrow, I'll send you a message or I'll put a 0 and you guys go, ooh, don't worry, just send it in and I will take care of it. And I'll put your 1 in so you get your point there as that you've been here. Any questions for me at all tonight? I'll be doing